Did you start? Yeah. So everyone has to click continue for the recording to be able to happen. And so we are very lucky to have several people on the phone today to help out with our case conference. Hopefully the majority of you got to watch the videos that we sent out for today's topics. I am pleased to have Dr. Westrak on the phone with me to help with the tumor, and then Dr. Gajendran, who is a hand surgeon at Kaiser SF, who gave you guys an excellent lecture, is also on the phone and has provided some of his cases. So you can see him and say hello. So what we're gonna do is go through several case studies. I think we have 7 or 8 today to try and get through in an hour, and Dr. Immerman, I think, is also on the phone, and so we will be able to, Igor, chime in for anything that you want to comment on. But let's get started. And the way we're going to do it is we're going to do a little hand anatomy and pertinent hand anatomy related to cases. We're going to do imaging related to tumor. So Dr. Westrak and I are going to pimp back and forth. So that means that you'll need, audio on when we ask you questions. Okay, so here we go. And I have to minimize you guys. Okay, so the first case we have is a 68-year-old male who presents with a large left index finger mass. He cut himself, a year ago with a pocket knife, said the wound never healed. Over several months, he tried some treatment for it, thought it was maybe fungal, waited to seek care. And then long after, he sought care from a hand surgeon who then referred him on to see Dr. Westrak after getting some imaging. So these are the pictures that we have in the chart. So of our interns, Sergio, can you tell me what you see here?
Fungating mass on the index finger. Kind of looks like it involves the PIP joint, and it's looks circumferential there, but I can't really tell because I can't see the ulnar side.
Yeah. So what kind of structures are you worried about that involving there?
I think I'm worried about the extensor tendons there, and if it goes more polar than the flexor tendons as well.
Right. So you said joint, flexors, extensors, obviously neurovascular bundle, things like that you're thinking. And both PIP probably, and getting close to the MP joint up here, kind of hard to see. And then you notice that it's kind of circumferential. It almost looks like you're staring at a lateral band right here. It's hard to say from the picture. Okay, so Matt Churches, what are you thinking about this? Where's your mind going?
Yeah, so this looks malignant to me. So I would think like some sort of likely soft tissue tumor of the hand, maybe involving the neurovascular structures, maybe involving some of the bone. So I'd want to start a workup.
Matt, this is Rosie. So what makes you say this looks malignant? I mean, you don't have microscopes for eyes. So what about this is making you concerned?
Yeah, so it looks kind of fungating. It looks heterogeneous. It's kind of irregularly shaped. It's not like a symmetric solid. I imagine it's fixed. So maybe all of those things would kind of lead me to think that it's probably something more malignant.
Okay, yeah, and at this point, like when you're seeing a patient, it's better to say things like concerning or aggressive. Jumping to malignant, although you very well may be right, is very scary for patients. So without getting a sample, it's really hard to say something like that. But you can say, well, I'm worried this is an aggressive mass. This is concerning because it's fungating. So forth. And what about the history, specifically in this patient? Is that making you think of any diagnosis in particular?
Back to the history slide.
History is an old man with a chronic wound. There you go.
So I know that I forgot the name of it, but I know that there's a like a ulcer, like with chronic wounds, you can get like an ulcerative cancer. It's something ulcer. I can't remember the eponym. Is it Marjolain's ulcer? Yeah. So that would be something that I would think of.
And what kind of tumor evolves from a Marjolain's ulcer?
That I do not know.
Okay. Anyone in your class want to, or the class above you?
Squamous cell?
Yeah. So this would be a really concerning history for a potential squamous cell. And versus if you were to see a different type of tumor in the hand, you wouldn't expect it to coincide and evolve with a non-healing wound. You know, that you can have a tumor that fungates and then creates a wound. So I've definitely seen that where tumors growing so aggressively breaks through the skin and then it becomes fungating. But in this instance, his hand was fine. He had an injury. It went on to get infected. He developed a wound that never healed, and then he developed a fungating mass. So that's much more concerning for something like squamous cell arising from a Marjolain's ulcer.
Yep. So we did have x-rays that were read as normal, but they're purged from the system. So let's move on to studies here. So here's the MRI, and I'm going to play it for you.
In addition to the MRI, Charlie, since you were just on tumor, what would you do next?
Well, I think it could be pertinent to get a biopsy.
Yeah, and what kind of biopsy do you think you could get for this?
I do think you could probably do this in clinic. You could probably get a core biopsy of the mass.
Yeah, you could definitely do a core biopsy of the mass, or you could even ask dermatology to do a punch biopsy, or you could yourself get one of those little punch and do a punch biopsy. But yeah, we definitely need a biopsy.
And then,
Rosie, is this somebody you would send to FNA, like your clinic, or would you actually refer them on to derm, or do you do this in your own clinic?
I think this is something we'd probably do in our own clinic. You know, we can get those little punch guns. We also have a nice core gun that we could do. But I think FNA, this is probably just too easy for FNA, and it costs a lot of money. So I think we try to get something in the office.
Varun, do you have like biopsies in your office that you can do, or do you refer these on? Have you seen this, or does this just go straight to derm for you? I think you're on mute, Varun. No, we can't hear you. Yeah, we'll let you work on it. Okay, so just, you can keep trying and chime in when you hear. Rosie, you want me to go to the next slide?
Can I ask how often you're sending these patients to derm to get biopsied? Maybe it's just my recency and, but I've had a couple of patients who've had quote unquote biopsies from derm, and they've like all had wound issues, or I've seen a couple with wound issues.
Yeah, well, to be honest, this is the type of thing that comes to us through derm. Yeah, you know, so this is something that would get sent to derm. The punch biopsy happens there, and then they get an MRI like this and see the extent of the problem, and then send the patient on to us. So I'm not routinely sending people to derm.
All right, should we talk more about, so the path? Sorry, it's
MRI.
All right, so plan from here. So Rosie, who you want to?
Well, so we'll tell you what it is.
Okay.
So it's squamous cell, so invasive squamous cell. So Abhi, in addition to that MRI, what would be another imaging study we should get, and why, for someone that now has biopsy-proven squamous cell?
Well, with squamous cell cancer, then I would want to make sure there's no metastatic disease. So I get CT chest, pelvis contrast.
Yeah, so I think that's always a good place to start, especially when you're dealing with a sarcoma, because most sarcomas metastasize to the lungs. But squamous cell carcinoma also tends to metastasize to the lymph nodes. So we do need to get a study that's going to show us the lymph nodes. And in this case, a whole body PET CT scan actually will show you the lymph node basins. And I think you have that here, Nikki, right? So in his instance, he did have left axillary lymphadenopathy. So now we know that his lymph nodes may be involved. So we will have to do something to sample those lymph nodes at the time of surgery. So I just want to make sure that that's clear. So for squamous cell, you need to investigate the lymph nodes.
Dr. Schroeder, if this
Yeah.
this came into your clinic, are you sending this to Dr. Wistrak, or are you ordering this study yourself?
I would call Dr. Westrak, since we share a clinic day, and discuss like what needs to be done. But I mean, we certainly share tumors, and I'll start the workup and get her over to them. But I think I don't have the knowledge to order like the right PET CT, all of that stuff. So typically it's, if there's something I'm concerned about, then I'll reach out to her and then get it to her when I start the workup.
Okay. Yeah, okay. Makes sense.
Igor or Varun, if you guys have any other chiming in things, let us know.
And maybe we should, go ahead, sorry.
I don't have anything smart to say.
Let's go back to the MRI and Monica. So we now have this gentleman. He's got this invasive squamous cell. You saw the image involving the index finger. Here's the MRI. He does have potential nodal involvements. What is your plan for local control? What do you know has to be removed? And then what are some other considerations?
Yeah, so for just talking about the local control option, so I would say that looking at the MRI and the clinical imaging, his index finger will need to be amputated. Likely would do a ray resection since it looks like it extends proximal to the MCP joint. And then radially, it didn't look like it extended into the first ray or into the thumb. And then ulnarly, it does look like there's at least some like edema or some, increased signal that extends more ulnarly. So at the time of surgery, I guess I would counsel him that we would need to do at least a second ray resection, and then potentially need to also do a third ray depending on what path looks like intraoperatively, since it does look like there's some extension into the third ray on the MRI. And then like you mentioned, there's a lymph node that's positive. So you need to plan at the time of probably local control, having someone potentially do the lymph node resection. I think probably would try to time those together.
Yeah, that's perfect. And that's exactly what I was thinking. And fortunately, the patient made it really easy for us, and that because I kind of said the same thing. Well, we definitely have to take your second ray. We may or may not be able to save the third, and we can send a bunch of frozen sections at the time of surgery. And then he said, well, can you just take the third ray as well? I don't even want to risk it. And wouldn't it be easier for you to close the wound if you took both? And he made it super easy. So we did a double ray resection, and we used the ulnar skin of that third ray and flipped it over for closure. And it worked really, really well. And Nico, I think, helped with that one. Mm-hmm. But squamous cell has a really high local recurrence rate because it's traveling in the dermis and it's not an obvious mass. So Igor, you and I remember when we had that patient, we thought we could maybe save a ray, and we kept sending frozen sections, and to the eye it looked fine, and it was positive, and we ultimately just did a transradial amputation because we couldn't get a negative margin intraoperatively.
Yeah, I remember that patient.
Yeah, so more is more, I think, in squamous cell of the hand, and if you can plan for a wider resection up front, you won't have so many local recurrences.
Yeah. Varun, are you working? Is it working now?
Yeah, can you guys hear me?
Yeah, excellent. Hi, welcome.
Oh, perfect, thanks. Sorry about that.
No worries.
Yeah, to answer the question you had earlier, I generally just will consult with my derm colleagues and sometimes general surgery just to get some advice about the general workup. Eventually, I end up doing the definitive surgery for it because it's kind of our area, but I want to make sure that I'm not missing anything, as Rosie was saying, with checking the appropriate studies, which I don't do all the time. So I primarily see myself as the surgeon taking care of this, but I definitely get their help as far as working it up and doing all the stuff that needs to be done.
The other thing, Rosie, is like I feel like many times when we see squamous cell, it's just like eaten up the whole hand, like the guy that we had at the VA that we did the forearm amputation on. Remember?
Yeah.
From like a long time ago.
Yeah.
So sometimes it's like a pretty easy conversation in these patients because they have these like ginormous fungating masses and they just want it off. So
Yeah,
like they tend to be the easiest ones to have that discussion with.
that's very true. Like this guy's, it smelled so bad, and he's watching it get bigger and bigger, so he wants the problem solved. Yeah, that's a good point.
All right, should we move on? Is there anything that you want to talk about from the path?
So the path, when you're looking at squamous cell, so anything that's a carcinoma is from an epithelial lineage, and those cells tend to want to make glands. They're more cuboid. This is a terrible path slide. I apologize. It should be zoomed in. But you're going to stain for keratin. If it's a sarcoma, it's going to be a cigar-shaped spindle cell. It's not going to be cuboid. It's not going to be trying to make glands, and it will not stain for keratin. So those are just some weighty questions.
And squamous cell is the most common malignant hand mass overall, right?
Yes, I mean, we always kind of break it down into sarcomas, but I think you're right, Nick. I haven't looked at the numbers specifically for that, but I do think it's much more common than any sarcoma in the hand.
Yeah.
All right, so here's our next case. So we've let me minimize this so I can actually read. 31-year-old who's had a right forearm mass. He says it's been going on for several months, but growing over the past few weeks. Some numbness and tingling in his fingers, obviously limited range of motion. He's been wearing a wrist brace for comfort. Initially thought it was just carpal tunnel, otherwise healthy. And on exam, he's got a 5 by 5 centimeter well circumscribed firm mass over his volar radial aspect of the wrist, and there's surrounding edema. His sensation is grossly intact. He's got a minimal functional arc of motion at the wrist, about 20 degrees total. And otherwise he's neurovascularly intact. So Joey, you're on the line. Talk to me, or talk to all of us about these x-rays.
Nice.
Yeah, AP and lateral of the wrist. Starting in the AP, it looks like, at the distal radius, there's a fairly large, hypo, I guess it's pretty lucent. It looks well circumscribed. Just within the bone. I can't say I see much invasion in the soft tissues, but looks like there's definitely some sort of bony tumor in the distal radius. It looks like it doesn't really extend into any of the other, into ulna or into the carpal. But yeah.
Do you have anything on your differential?
I mean, in the hand, I guess I think of inchondroma. I don't know if that's common in the distal radius also, but if this was in the fingers, I think that's kind of what they look like, but I'm not sure what's common really in the distal radius.
That's fair. Can someone maybe jump in about some of the imaging features that would steer you in certain directions? So thinking, could this be an enchondroma or not? And why does the imaging not support it? And what about the imaging leads you down a different path?
I guess I would say, I would describe this as like a lytic expand-style lesion in the distal radius that doesn't seem to violate the articular surface. And it's hard to tell, like Joey said, whether it goes beyond the cortex. I think the characteristics that steer me away from enchondroma is the lytic nature of it. And the characteristic, and for the same reason, it seems more consistent with something like, highest on my differential would be giant cell tumor of bone for this.
Right. So when you're thinking about cartilage tumor, you want to see evidence of cartilage in the tumor, and that on X-ray shows up usually as popcorn calcifications. If you're thinking of something like an osteosarcoma, then you need to see some bone formation in the tumor. What you're seeing here is a purely lytic expansile lesion in the distal radius, and involving the metaphysis and the epiphysis. Yeah. So purely lytic giant cell tumor fits that. Distal radius is a great location for giant cell tumor, and involving the epiphysis and the metaphysis is great for a giant cell tumor. It's also eccentric, which is great for giant cell tumor. And the fact that it has expanded out the cortex, but you can still see some calcification and some remnants of the cortex is also reassuring that this is consistent with a giant cell tumor of bone.
All right, so next step, so Ryan, what are you gonna do now? You're on mute. There you go.
So I think you should get further imaging of this. MRI would be a good choice. See, I like how they said my suspicion would be highest for like a giant cell tumor or CT and MRI. My suspicion is highest for a giant cell tumor, which, yeah, based on the imaging, you basically have this large. So on the CTs, you see that there's a large expansile lytic lesion. On the MRI, you see that it has kind of septated with a bunch of different pockets in there. So beyond that, you would also want to get some evidence of what's going on in there at the tissue level. So I think a biopsy is also a good idea for this as well.
So Ryan, those pockets, what's kind of a buzzword for those?
Septae, or what do you mean?
No idea.
Like diagnosis, you mean?
No, like how would you describe that? So can you scroll through the MRI so we're looking at like the sagittal or the axial? Yeah. So what do you see there?
It's kind of it's like it's cystic, let's say, like multiple fluid
levels, right? So do you see how within those areas, those kind of cystic areas you see this horizontal line, and it's a little bit lighter on top and darker on bottom? Do you see that? Yeah. So that's a fluid level. Like if you were to take a vial of your own blood and set it on the counter, it would layer out. So that's what's happening here. So we're seeing a bunch of fluid levels throughout the mass. So giant cell tumor, we all agree this looks very concerning for that based on the x-rays. Is there another tumor that we should add to the differential based on these fluid levels?
I think ABC also, I think is what.
Yeah, so now we start thinking about, aneurysmal bone cyst because of these fluid levels. An interesting aneurysmal bone cyst is a common secondary finding in giant cell tumor and chondroblastoma. So seeing these fluid levels doesn't sort of eliminate giant cell tumor as our number one on the differential, but it adds aneurysmal bone cyst to that as well.
Dr. Wishart, what do you mean by a secondary finding? Like, is it
Yes.
not aneurysmal bone cyst then?
Right. So you can have a primary aneurysmal bone cyst, or you can have a secondary aneurysmal bone cyst. A primary aneurysmal bone cyst is it arose on its own, and it has a distinct mutation where you have something called USP6. So that's kind of the fusion protein that you're going to see. But it can be a reactive process as well. And so you can have areas of aneurysmal bone cyst within a giant cell tumor or within a chondroblastoma, and it's a purely reactive phenomenon, and it will not have that USP6 positivity.
Awesome, thanks.
It is awesome. Yeah, thank you.
Dr. Talking Dr. Schroeder, can I ask, is a CT part of your standard workup for a giant cell tumor, or were you concerned based on the X-ray findings because it looked so lytic and there might have been cortical erosion?
Are you asking me or Westrack? Sorry. I got this, so I actually saw him first in clinic and got this imaging before I sent him over to Dr. Westrack.
But that is helpful to determine if it's gone into the joint or not, because the MRI, sometimes it's actually really hard to see the cortex. So I think the CT scan is really helpful.
Yeah, I mean, for me, it's, you can, if you look at the CT scan, I forget if I included, but you can see how this like tiny articular shell of bone, right? Because at that point, you have to just decide whether it violates this and if you actually need to talk about something more extensive. There's certainly, you know, different treatment options that we're going to go over in a second.
Thank you.
Yeah.
Would you also get a CT chest at the same time if you're going to get a CT of the wrist?
You do need a CT chest in giant cell tumor of bone because there's a risk of these air quotes benign metastases, and so it's probably about a 3% risk, and we'll get CT scans of the chest every 6 months. I usually wait until we have a histologic diagnosis to get the CT chest.
All right, so this was taken to the OR. Let's see who we got here. So Nick, you're there. Yep. You're going to take this to the OR. What do you want to do? What are your thoughts? Are you going to do a biopsy first, or are you going to take it out?
So I think by this time we'd already have a biopsy. Or if I'm going to the OR, I know this is what I think it is. So you could always do a frozen.
Well, Nick,
what does that mean?
How did you get this biopsy? Please tell us.
I guess you could take it at the time. It's just one surgery, then one approach, and just take it frozen at the time.
Yeah, that's what we did. So my thought process is, if I'm leaning really heavily in a certain direction, if everything's pointing towards this is probably giant cell tumor of bone, possibly ABC, then I'll plan for an open biopsy at the time, you know, pause, check frozen, and then plan to proceed with intralesional treatment if the biopsy confirms. And then I'll always tell the patient, but if on the frozen, they think it looks very concerning, we're going to stop with just a biopsy. So that's sort of my algorithm for giant cell tumor of bone.
Yeah.
So Nick, what's your surgical plan? So let's say you're going to take it. Dr. Westrack's in the other room, and she says, all right, go ahead and do the biopsy. What are your thoughts on how we're going to manage this?
So supine, hand table, trans FCR, come down, expose the bone, and then I'm going to make a cortical window. The cortex may be broken in and of itself, and then I'm going to curettage this thing. I'd probably ask for a high-speed burr.
But first, you're going to take your biopsy, right? So you're not going to make a huge trans FCR, right? You'll draw your trans FCR approach.
Yeah.
Right? Because doctor, you want to know, do I need to take the skin with this? Do I need to, you know, what part of this is important to your like incision, right? Because sometimes they want the skin with it, sometimes they don't. So do you think Dr. Westrack wants skin with this?
I don't think she's going to, if this is just a giant cell.
Okay, so you're going to make a small incision.
Yep.
And then how are you going to get down to the bone?
I think I would do. I would do a trans FCR. Yeah.
So you're under trans FCR, and then the thing just starts bleeding like stink. Now what? Because that's what happened. And Dr. Westrack was not in the room.
I'd first pack it off. Are we under tourniquet? You should be under tourniquet.
Yeah.
And was still bleeding.
It's not like arterial bleeding. It's just bleeding a lot.
Yeah.
Like, not like, giant cells don't normally bleed like this.
No, not like a renal.
But like we literally made our trans FCR, you know, we moved the FCR aside and made an incision, and then this thing just started gushing.
Mm-hmm.
Is that weird?
I think it would be weird. I think it would be contained though. That may just be the tumor itself. As long as we're under tourniquet, I don't think this patient's going to bleed out. I'd probably put some pressure, elevate, regroup for a minute or two, and then open up and just see if I can find where this source is coming from. I may need to increase my exposure just to get better visualization.
Well, it's not arterial bleeding, right? It actually was just the tumor.
Yeah. So it should stop once we get after the tumor.
Yeah. So
that was before you even got to bone. It was bleeding that?
No, I mean, so basically the minute that we moved FCR, like, I mean, the cortical shell was so thin that you were inside the lesion within like a second, and it was just a very bloody lesion, like very bloody.
I see.
Is that typical of a giant cell to be that bloody? Or is it more like an ABC? Yeah.
It can be really, really bloody, especially.
Okay.
Yeah.
Yeah.
Especially with the secondary ABC.
Got it. Okay.
It didn't look like your standard kind of like snotty giant cell tumor, you know, but we sent it to path, and then it was, right? So now you said you're getting down, you're going to curette it out, send off your specimen.
Yeah.
What's your treatment plan? Do you want me to go back to x-rays, or you?
You can pull it up again. But I think if this is a giant cell, we know it's a giant cell now. We're going to curette it out. We may have the high-speed burr. Then I have to decide what I'm going to put into this thing. You know, what kind of grafting material I want to use. I think I would probably use cement. Something that it'll allow this person to immediately weight bear, and then it would still show a recurrence. I'd probably use cement.
Okay, so the couple considerations that you want to think about is stability of the bone, right? Like there's not much, you can see there's not much bone here, and I don't know if I have the axials or sagittals, maybe I do. You know, there's not much of a shell of bone that you see here, right? So you can cement it out. The other thing is cement right at the articular surface, right? You worry about the heat of the cement on the articular surface. And then, you know, so then you have to say, do I want to just pack this with cement, or should I pack it with cement and then plate it like a prophylactic plate on top, right?
I don't think I've seen too often putting a plate on this. I probably would not put a plate on it. Yeah, I haven't had experience with that, but I probably would not put a plate on it.
Just out of curiosity, how do you plate when it's like that huge lytic lesion? Like what are you getting fixation in distally?
Quickly, the cement.
Yeah. So you can anchor the plate in the normal bone in the shaft, and then you can you're using the plate as rebar, the screws as rebar in the tumor with the cement. Varun, have you had cases like this where you go straight to something more radical, like a resection?
I have not personally in my practice. I've seen a couple in fellowship, and there was one that was very similar to this one, where we were prepared with an osteochondral allograft, and that's what we ended up using. It actually looked very similar to this. It seems to me, looking at this, that the shell, you know, if it's anything at all, doesn't have any real structural integrity. So, you know, I wonder if that would have been an option here as well. I would probably have considered it, but I have seen the rebar type construct. You know, with you probably know Rafi when I was in residency in the pelvis, and that seems like a good option here as well.
Yeah. So the problem with this is it has a super high local recurrence rate. For giant cell tumor in general, has a reasonably high recurrence rate, but in the distal radius, a very high recurrence rate. So we did talk to him about what the wide resection options were and the function afterwards. So he knows that that's kind of coming if this comes back, but we thought it was worth a chance, given how young he is, to try to save his native wrist joint, and, you know, see if we get lucky. But what we did is we took the pronator quadratus with the with the bone window volarly. So try to use that a little bit as the margin volarly. And then in addition, Nick, to your high-speed burr, we also used argon beam along the interior to see if that helps with local recurrence. But I think this is a really tough location because unlike the distal femur, where if you're going to do a wide resection, you can just do a nice endoprosthesis and have a pretty reliable outcome. I think the function at the wrist, you're sort of, it's just a tough location, I think.
And you favor argon beam over like phenol or cryotherapy, some of the other local adjuvants?
I never have used phenol. Liquid nitrogen, I think, actually works very, very well. Here at UCSF, it's just been like painful getting liquid nitrogen, and we have argon beam so readily available. That's why I use argon beam.
Okay.
Oh, and that's coral up into the right along the surface. So we did a combination of coral and then the cement.
Nice.
Isn't giant cell the one that has some evidence that denosumab is helpful for it?
Oh yeah, great question. So denosumab is quite helpful, but the problem is you can't really come off of it because denosumab targets the reactive multinucleated giant cells and not the actual tumor cells, which are the mononucleated background cells. So it does an excellent job of ossifying the lesion and preventing growth, but then you come off of it and it recurs. So it's really, I think in my practice, I'm using it for giant cell tumor of bone kind of in the sacrum where surgery would be incredibly morbid, and keeping these people on it indefinitely, just not sure how long they're going to stay on it. But in this case, if we can treat it surgically, it seems to be better to treat it surgically. And then if you use it before surgery, it has a higher local recurrence rate following curettage, because what happens is the bone ossifies around these tumor cells and you can't get it all out.
That makes sense. And then there's no like post-surgical indication for it because at that point, presumably the tumor is gone.
Well, it's definitely indicated if there's a recurrence. So, we can talk again, like if there's a recurrence, okay, we can do a resection and an allograft, or we could put you on denosumab for a while and see how you do and kind of go from there.
All right, we're going to move on to another case. So this is a case of Dr. Gajendran's. So it's a 32-year-old female right-hand dominant with a painful subungual right ring finger for a year. So she states it's always been sensitive and painful to the touch, but gets worse, has occasional night pain that keeps her awake. And then on exam, it has some bluish discoloration in the middle of the nail plate, and she's very tender to the touch. So Ellen, do you have any thoughts on this?
So the fact that it's getting worse is concerning. And I'm thinking about like a glomus tumor.
Okay. Yeah. So what do you know about a glomus tumor?
It's a tumor of the temperature regulation cells in the subungual region. And I believe the prognosis is not good.
What do you mean by that? You were so perfect up until right there. You did a great job. Prognosis is not good if you don't do anything about it. So you're correct, right? Yeah. So let's see, Marcus, what do you want to do on this patient? This is what you have so far. I know you've seen one of these. So what are your thoughts? You're on mute.
Everything in the story points towards a glomus. I would think I would still want to get an MRI just to make sure that we're not missing anything, that this is not what we thought it is. Or yes. We'd have X-rays in clinic, but
we do have X-rays, yeah. And so it looks ring finger, right? So what do you see on here? So it's ring. They're pointing to you that it is the ring. Do you see anything here?
Yeah, I think I see maybe like a little bit of a divot in the cortex there over the distal phalanx. Like something is pushing on that.
Like right here, right?
Yeah, it looks like a little scalloped in there.
Okay. And so you want an MRI on this. So just so you know, I would say Igor and Varun, you can chime in, but oftentimes these are missed over and over, and they're like, I've seen patients referred for like arthritis of the finger or trauma of the finger, but the story is really classic, like really classic. It's like the exquisite tenderness to the touch. Like the patient, one of the patients, I don't know if Marcus is the one that we did together, but she had like pushed her finger open on a door walking into like a store and like hit it and had a little bit of blood. And so then she'd seen a doctor who told her that it was like, oh, it's an old fracture. And then she'd seen another doctor who said like, you have arthritis. And then she saw another one. And then finally she came to me, and like the minute that I saw her, I was like, you couldn't see, she didn't have a blue hue, but it was like, this is definitely a glomus tumor. So Igor, Varun, any other comments?
I totally agree. And some of my happiest patients have been glomus tumors because they feel like finally someone figured it out and then fixed their pain that's been there for years. So absolutely.
Yeah. Varun, have you seen
Yeah, I totally agree. I mean, I picked a pretty classic case, but we all see this a lot. And I think a lot of these, as Dr. Schroeder is saying, they don't show up with a purplish hue, but if you listen to them, they'll tell you it's right underneath the fingernail. And if you push, you can even use a pin, and you can push in spots around there, and there'll be one spot that usually is very sensitive, and everything around there will be relatively normal. And immediately that should cue you into a glomus tumor. There's not a whole lot else that could cause this unless the patient is, has secondary gain issues. And right away you get an MRI, and you're not often surprised by what you find.
Yeah. The one thing is just beware, because oftentimes if you have an MRI that might not be defined enough, these can be missed. So we had a discussion in our journal club going back and forth about this like very classic patient, classic glomus tumor. Imaging was like totally negative. And everyone was like, get a better image. It's going to be this, it's going to be this, or just go into surgery. You're going to find it. You're going to find it. And he ended up getting another, like a repeat MRI that actually did show it. That was like, I think had a specific extremity coil. Rosie, do you have any like comments on imaging for these?
No, I think MRI is probably with and without contrast is probably the best.
And so Varun, how do you approach this surgically? Or you're with Aaron Kim, who's one of our residents going into hand. Aaron, you and Varun are going to do this case, Dr. Gajendra, and you say, and tell him what you want to do.
I think he would, I've never done something like this, but I think he would start with removing the nail so you can access the tumor directly. And then start with a biopsy to confirm that it's a glomus tumor, although on the MRI it does look like it. It's hyperintense on the T2 and dark on the T1, and it looks pretty homogeneous. But there's also malignant things that you wouldn't want to miss, like a melanoma or a squamous cell that also can present in the subungual as a painful mass.
Mm-hmm.
Yeah, good. So I think based on the MRI, we're fairly confident this is a glomus tumor. At least I would be. So I'd go in with a plan for definitive treatment, basically removing the whole thing, and that's going to be your biopsy. So excisional biopsy. So I remove the nail plate, make an incision, longitudinal incision of the nail bed, and just kind of make some flaps. And this one is large enough, it's going to be obvious, you can see it. Some of these can actually be, as Dr. Schroeder was saying, you can have some satellite lesions that are adjacent and you can miss them on the MRI and then you can actually see them. I've had that happen once. So I look at the entire nail bed or underneath the nail bed to make sure that I get all of the, whatever looks like tumor. And you just basically close the nail bed, replace the nail plate, whatever your method of choice. And then, as Igor said, they're really happy patients right away. You call them the next day and they're already better, despite this traumatic, operation that you've done to their fingertip.
Do you ever need like a little fat autograft or something if it's a large defect that you have to fill in after a resection?
That's a good question. I've never needed one myself. I've never seen that much bone destruction. It's usually just, scalloping and kind of erosion through the dorsal cortex. But I've not seen them be so aggressive that I actually need to, replace the structure of the bone.
Yeah. I did one recently. It was like a 3-time recurrence patient, rosinosis patient, but she had previously been done once through a volar approach, which I thought was pretty interesting, and then through a lateral approach, and at that time had some bone grafting done. So, typically like a glomus tumor is like a well-circumscribed little thing that once you make the incision, it almost like pops out. That's how my experience with it has been. They're really satisfying. You kind of can just take a freer and it'll pop out. But this one was very difficult to assess even what was tumor and what was not. The pathology actually came back as giant cell, so we got at least some of it out, but it was kind of hard to discern. Rosie, do you see anything on the path slide here?
No, but I mean, these cells almost have the appearance of myeloma. It almost looks like the clock face nuclei, but that's not really what you're seeing. So you're just sort of seeing this speckled, very round nuclei throughout the whole lesion, fairly uniform.
So you'll see moderate pain and temperature. So they will tell you that like in cold weather, it's extra sensitive, and it's just very tender. All right, we'll go through 2 more. So 70-year-old gentleman who presents with a mass of his left hand, who was referred by a hand surgeon. He had a prior MRI in 2017. He noticed that his left thumb was just getting progressively larger and harder over the last year. No functional limitations. Wasn't really complaining of grip issues. Past medical, he does have a history of basal and squamous cell carcinoma, which I think was on his back. And then he had quit tobacco many years earlier. No history, no family history of tumor. Okay, so who we got? Let's see. Howell, what do you see here? Ready?
I think what we see here already is on this axial slice, kind of on the volar surface, you have this large heterogeneous mass that I think doesn't look like it's soft tissue. Doesn't look like it's invading into the bone. And that's going, it looks like it's going to the first web space. So in the 70-year-old gentleman, history of BCC, SCC, because he's older, I think one of the things that I would just be concerned about is for metastasis. Just have a keen eye out for that.
So what is your kind of differential looking at this? What are you thinking?
In terms of my differential, I think it looks more, has more features of being malignant and benign to me, just because of the heterogeneous nature. I'd be thinking, some sort of soft tissue sarcoma, it could be like a synovial sarcoma, or like I was saying, like a metastasis.
So what would you do next?
I think the next thing I would do is I would try to get other imaging to rule out if there was like another primary source, like a CT chest, and I think about my biopsy plan, whether or not this is something that you can get in clinic through like a core biopsy, or is it something that you have to refer out for a biopsy.
Okay. I mean, I think your thought process is good. The thing to keep in mind is metastases are most common when you see a bone lesion in an older person. So if you have a bony lesion in a 70-year-old, that's 500 times more likely to be metastatic disease from somewhere else rather than a primary bone sarcoma. In a predominantly soft tissue mass, it's really rare to have soft tissue metastases. You can. Renal cell carcinoma can go to soft tissue. lung cancer occasionally can go to soft tissue, but it's pretty rare. And actually, sarcomas are pretty common, soft tissue sarcomas, relatively in an older age group. So while metastases are possible, I think a primary soft tissue sarcoma is probably more likely, although the hand is a really unusual location. And I think the studies, the staging studies that you may want to get would probably be a whole body PET CT scan, because it can give you information on how FDG avid this lesion is, which can give you more information about whether or not you're concerned, malignant, or aggressive or benign. The heterogeneity, I think, is very concerning of this, making you worried that this could be an aggressive lesion. And so a biopsy would be really important to get next. And I think you could get a core biopsy in the office. At this time, I think I sent him for an FNA just because that was more my workflow at that time. If I saw the same patient today, I'd probably get a core biopsy in the office.
Yeah, so I just threw in a lipoma here for reference, right? So if I had to look at that lesion, I would say it looks pretty well circumscribed, but certainly the heterogeneity in the mass versus this lipoma, that's very similar in size, certainly on the other side of the corpus here, but you can see just how different it looks on an MRI because it's consistent and it's it's homogeneous in nature. You can see both on T1 and 2.
There's a quick question about the biopsy. A core biopsy is a better biopsy typically than a fine needle aspiration, correct? Yeah. Like, because you get the
much better.
So why would you? So what situation would you do a FNA versus like what?
So again, at this time, this is a patient of mine from a little over 4 years ago, and that was before Melissa started, and my clinic was pretty congested, and so it was easier for me to send these patients for an FNA than to do the biopsy myself. But as you'll see, actually with this case, I became increasingly dissatisfied with the results from the FNA because it's just a small tissue. They're only looking at cells. So then I just started doing the cores myself. And so now if I saw this patient, I would do the core biopsy myself in clinic. It's just a lot more tissue.
Yeah, so here's the FNA, right, which was consistent with a soft tissue sarcoma. So Monica, just quickly, if you're taking this to the OR, what are you thinking? What do you want to do?
So for soft tissue sarcoma, you need to do like a wide local resection, most likely. So just looking at the location of it, I would do probably a Palmer approach to the hand. And then it's located kind of right over your thenars, which is difficult, I think, from just thinking about like function afterwards, like counseling the patient on that probably preoperatively. And then approximately, it looks like it extends at least to the level of the carpal tunnel, possibly further into the forearm. So I would do probably a kind of direct approach to it volarly, and then try to develop a plane between, because it looks like there's a capsule kind of around the tumor more volarly, so I would try to develop a plane between the capsule and then the surrounding soft tissues.
What? Wait, what?
Well, I mean, it looks like.
No. Oh. If it's a sarcoma, we have to get a margin, right? So you don't want to develop.
I guess you would keep probably the skin then, since it's so superficial. And then I guess once you go deep to it, you would keep a margin of tissue on the capsule, and then send your pathology deep to whatever you remove. And then if the margin after the frozen comes back negative, then in terms of closing the wound, since you're probably taking a large portion of the volar skin, you would have to think about potentially like skin grafting over this, I think, if you can't close it primarily. Yeah, those are my thoughts. after, definitely not leaving the skin. This is the takeaway.
Yeah, no, I mean, that's about right. It's just, you want to take an envelope of normal tissue around it as a margin, as much as you can. So I think there is, like, we took a little bit of skin, but we made just like a skin only flap and left some of that fascia with the mass superficially. And then deep, we took a little bit of this muscle as the margin deep. And then we left some, so we completely took, I think, what was it, Nikki? Abductor pollicis?
APV from the bone. We took it off the bone,
took that, and that was kind of the whole envelope around the mass, and then left the other opponents and stuff with the hand.
Yeah, the other thing is, like, although it would be great to do an extended carpal tunnel just from like the ease of getting this large mass out, it looks like it's not involving the carpal tunnel, so you wouldn't go into the carpal tunnel. So they just stayed in the thenars to take this out. So, so here's the path.
So this is just my point. So the FNA only looks at cells. So the FNA from this case did not happen to capture these crazy, bizarre cells. So the FNA just sort of showed some slightly atypical spindle cells. And then when we got the whole mass out, then the diagnosis changed from a low-grade sarcoma to a high-grade, grade 3 out of 3 sarcoma. So that's one of the reasons I'm using FNAs a little bit less. I'll still use an FNA for a very small lesion that the core gun, which I think you've all seen now, is just too aggressive for. So in that case, I'll use an FNA for small lesions.
Do we have time, Igor? Can we do one more case?
Up to you guys. I mean, I have probably could be 2 hours, but I can always cut it down, so it's fine. Whatever you want.
You can't talk for 2 hours, they'll kill you. We're gonna do one more, just one more. Let's, we'll skip this one. This is a giant cell that we just took out. That's a giant cell of tendon sheath. So here's just, there's a couple more slides. They'll be on, you can see them on Box, but here's one more that I wanted to go over just because this is a case of Dr. Gajendran's. It's 45-year-old right-hand dominant male with a enlarging left elbow mass for 1 to 2 years. No symptoms, just concerned that it might be malignant. Unexamined, a firm, deep 3-centimeter mass in the lateral forearm, mobile. Doesn't have a Tinel's. Transillumination can't be done because it's just too deep. And overall, no sensory disturbances or motor weakness. So let's see. Abby, you want to comment on your thoughts here? So here's your imaging. You're on mute, just so you know.
Oh, okay. So, firm, deep mass. Can we scroll through the imaging? Where is it?
It's not, this is just a photo. You get that?
Oh, okay. So it has a hyperintensity there, matches kind of, what was the other, can I see the other, the T2? So it's bright on, oh, this is T1, so bright on T2. It's well circumscribed, doesn't seem to have any invasion anywhere. Maybe there's a kind of a stalk coming off of bundle in between the radius ulna, but I think it's well circumscribed. There's some heterogeneity within the mass, and then how far down does it go? I guess we only have this one cut.
So what are your thoughts?
Target sign.
So Nick, what are you saying, and tell him, what do you think that?
I think this is sounding nervy to me. I know that Tinel's was negative, but I think I'd probably think something more like a schwannoma or something.
Yeah.
It kind
Or
of
like a
had
nerve sheath tumor.
Yeah, exactly. It kind of has that. Sometimes they talk about that, like that target sign with the nerve things, where it's high intensity more peripherally and then a lower signal centrally, very well circumscribed. If we had the coronal, sometimes you can kind of see how it's more like a spindle, almost like a string sign. But I don't see that here.
Okay. So what would you do, Nick, if you think this is really a peripheral nerve sheath tumor? What are you thinking about?
Mm-hmm.
Are you gonna just take it out? Are you gonna refer it on? What are you gonna do?
Yeah. You said he's been present for a couple years. Tinel's negative. He has no nerve symptoms, right?
Not per the note. Yeah.
Yeah, for the note. Why is he in then? Why is it bothering him?
He's worried about malignancy.
Oh. I don't think it's malignant. Can we tell him that? I would like to get I'd like to get some tissue, but maybe just go in for an open biopsy. But if this is a peripheral nerve sheath tumor and I take that whole thing out, he may end up with nerve symptoms after I take it out. So I may just try to get a tissue diagnosis and then talk to him and then leave it at that and talk to him and see what he wants to do.
Dr. Westreich, do you have any comments? For this, like, would you just go straight to the OR and take it out?
Most likely, given the history, nothing about this to me looks very concerning. So I probably would plan on doing an excisional biopsy.
Yeah. So here it is, like, just to talk about peripheral nerve sheath tumors. This is benign.
Yeah, this is just meant to show you that in schwannomas, you can have sort of this whirling pattern, and you can have areas of high cellularity mixed in with areas of low cellularity with these sort of wavy collagen-like fibers. That's kind of what you're seeing here.
And so there's benign and malignant variants, benign being more like the schwannoma neurofibroma. And then the malignant, the difference between the malignant and the benign is typically that it's on imaging, it looks less organized, right? Not as well circumscribed as the one that you saw here. And so just beware once you set it off for pathology and depending on what your imaging shows. Any other comment?
I mean, if the guy's asymptomatic though, don't you risk actually giving him symptoms by taking this thing out?
Yeah, definitely. And I think it's worth a conversation. You can always watch these. I'm currently watching a woman that has an asymptomatic one right where the perineal nerve splits off from the sciatic nerve. So we're probably just going to watch her. They do grow, even though they're benign, they grow over time. So you would have to warn the patient that we may need to take it out at some point, but the main indication is pain. Usually they do have pain when they're like bumping up against stuff in everyday life. So most patients want it removed because of pain.
Okay.
Do benign peripheral nerve sheath tumors progress to malignant, or is it more just that they grow and then like they're different tumors?
Yeah, they seem to be different tumors. Now, in someone that has like a neurofibromatosis, for instance, you do need to watch those closely because they have so many that statistically speaking, there's a really high chance that one of them will be malignant and behave in a malignant fashion. And those seem to start kind of slowly, and then you're following one for a while, and then it sort of declares itself as an MP and ST. But in someone without multiple neurofibromas, just like an isolated schwannoma, it does not have the risk to become later on malignant.
Yeah, I'll just say, Nick, those are all very good observations. I think those are important to think of, when you're in practice trying to manage these. The guy is totally intact, and so he's got no symptoms, and that's the first thing I was thinking. Last thing you want to do is give him a PI and palsy. but he was so pushy about having it removed because it was getting larger. And although it's slow, it does, for some patients, it's disconcerting depending on, how much they're concerned about cancer. And I told him that, that he wanted some sort of reassurance that it's not malignant. And as far as I know, there's no way to definitively say that it's not malignant just based on the MRI, because I think the malignant and peripheral nerve sheath tumors can look similar to a schwannoma on the MRI, and same with the neurofibroma. So I always have this conversation with them. I don't even know if it's going to be a tumor that can be shelled out easily. So I tell them if it's a neurofibroma or a malignant tumor, then we may have to resect the whole thing and reconstruct the nerve. And he was totally fine with that, despite that not being something that most of us would want to do. But fortunately, it did shell out for him. The odds were on his side. And I tried to put a couple of slides here with the target sign showing, something that you guys might see on your in-training exam. It's kind of a classic appearance for it, which you don't always see, but it's there. And these don't always have a Tunnel sign, but this case it didn't, but sometimes they do. And on exam, these kind of move in a transverse direction, but not up and down because it's attached to nerve. And it has to do with the string sign that's attached to nerve on either end. So those are all kind of things that should clue you in on as to what this is.
And did you do this yourself in your own practice, or did you have someone like Dr. Wustrak with you on board?
No, I did it myself. I think this is one of those things where, cancer and seeing enough of these that I felt comfortable. The ones that I need help with an oncologist are, the ones that are very concerning for a possible sarcoma. And I wasn't concerned in this case. So you just have to obviously adhere to tumor principles and make sure that you don't, screw anything up if you need to come back. Always be mindful of that. But if your index of suspicion is pretty high that this is a straightforward thing, you should just be able to take it out yourself, I think.
Got it.
All right. So,
sorry, can I ask a question?
Yeah.
So I saw a patient yesterday or 2 days ago. It's a 60-year-old male who has these. He came in because he has some arthritis pain, but also he's got these multiple subcutaneous nodules. The symptomatic ones are on the radial side of the wrist with a Tunnel on them, but they're on both extremities. And then he's got this, I wish I took a picture, he's got this large birthmark on his head. And he's never been worked up for anything. And I was thinking neurofibromatosis. Do you see adults present with that for the first time, or is it really unlikely?
You're muted, Rosie.
Usually it presents in childhood, but I think if you have a very mild case, I can imagine it, not becoming an issue until someone's older.
So far sent him for an MRI of his wrist, but what should I do? Like, let's say, show some masses, they're going to be like not really diagnostic with MRI. I may want to
maybe just do an excisional biopsy of some of the subcutaneous ones.
Okay. And then start with that. Okay.
Yeah. All right. So in the interest of time, we will defer the rest of this to maybe another day. But so I just wanted to thank Dr. Wustrak very much and Dr. Gajendran for doing this. And thanks for the cases. There's a couple more cases, and this will be on your box, so you guys can all reference these. And so thanks for staying tuned, guys.
Sorry, before the tumor people leave, can I ask a very quick question? Is there more of a hesitation to do radiation in the hand? Like for sarcomas that typically you would get postoperative radiation, like in the hand, you're like, oh, we won't do it in this case. So there's just more of a discussion around contractures and things like that.
Yes.
Yeah. Like for a lot of our squamous cell patients that have, digital squamous cell, we'll have a lot of conversations about whether or not radiation is going to be more harmful or helpful because of the contractures and things like that. For my patient that had the UPS in the thenar eminence, he did get radiation and his function has actually been fine, but that's a little bit different than like the end of a finger.
Thank you.